everybody. Welcome to a new episode of IBD Essentials. Today we will really try to switch gears again. We are moving a little bit to a surgical topic, and it's really a great pleasure to sit here together with my long-term friend and colleague Paulo Kotze from Brazil. He is probably one of the most eminent surgeons in the IBD field in the past years, had a lot of interesting work. He was traveling also a little bit around as he was staying in Canada. Perhaps, Paulo, you before we really start into getting to the real topics, you just introduce yourself and tell our colleagues what you did in Brazil and why you did move to Canada and then move back to Brazil.
Excellent. So yes, thanks for the opportunity to be here participating in this fantastic podcast as an experience. So I'm a colorectal surgeon by nature. I am dedicated to IBD for the last 25 years. But in Brazil, there is a different reality. We also treat medically our patients. We scope them, we operate on them. So we have a more holistic view of the patient. So usually we do our MDTs by ourselves because some units we have the same profile. And I felt that there was a need for me to increase my skills in medical therapy. So I spent a year in Canada, in Calgary, as a visiting fellow for advanced IBD program. I learned a lot, and I think now we are taking care of a lot of patients, both medically and surgically. That's my profile.
It's wonderful. And as I already mentioned, you are a real colorectal surgeon, so you do a lot of work, and the gastroenterologists usually feel that if someone of our patients is going to surgery, this may be a loss. But in recent years, we have really heard about exciting trials where surgery may be even the first-line treatment or may even help to prevent IBD. So probably it would be nice to discuss a little bit about this. And I think one of the stories which is now going on for more than 10 years is the idea to treat early Crohn's disease, early limited ileal Crohn's disease, just with ileocecal resection, and there may be probably some changes also due to the technical advancements. But this is probably something which is very interesting, and I think it really got attention when the LYRIC trial came out, and now we are at the 10-year level of the LYRIC trial. So perhaps you can explain a little bit the background and your opinion on this as a surgeon.
Fantastic. So the LYRIC trial is a very brave trial. It took long to recruit because, of course, randomization between surgery and medical therapy is not something we see every day. So it took 7 years to complete the recruitment for the LYRIC trial. So it was a very brave trial. And I think that if they did the protocol today, they would do patient preference trial because it makes more sense. So they randomized, ileocecal resection versus infliximab for localized ileocecal disease. And for the first year and then for the 5-year data, we saw very clearly that surgery was durable, inducing a remission strategy. And half of the patients after surgery did not have to go to any type of advanced therapy, which is a great sign. So not all patients, they probably need prophylaxis of recurrence. And not surprisingly, I would say that after 10 years following up those patients, we also saw the superiority of surgery in terms of therapy-free in the long term. So there were more patients without any therapy after 10 years in the resection group as compared to the patients that received infliximab. And some of them even needed resection. Of those patients with infliximab, they needed resection during the study. So yes, I think this data is very, very, trustable. That's number one. And the second thing is that it's replicable. So we also saw data from Denmark in a national database comparing patients that after 1 year of diagnosis that underwent either an anti-TNF therapy or a resection, or patients with localized ileocecal disease, we also saw the same trend. So after 5 years, 50% of the patients approximately had no medication, which means that there's definitely something there for the luminal disease. Early surgery plays a significant role on the control of the disease of those patients.
Paulo, is there a difference in the age of the patient? So would you do it, or let's talk about patient selection. So would you do this I guess for sure in the very young patient, because you may save a lot of medication over the years, or is there a difference if you go more to the elderly patient population?
Yes, the post hoc analysis of the lyric trial showed that the more you see, the place where you more see the advantages is in young patients. So the younger patients, they have a lot of advantage on not needing therapy over the long term. And I think it makes sense because we have a limited number of options for medical therapy. And again, younger patients, they have their full life ahead of time. So usually when we as IBD surgeons, we do not think only about short-term complications because this is typical from surgeons. I don't want my patient to complicate on the next 30 days or something, but what we need to pay attention is that 30 years ahead of time. So I think it makes a lot of sense for the young patients for us to have those advantages of the strategy.
Going back again to patient selection. So for me as a gastroenterologist, I have in mind these are the, let's say, very uncomplicated patients. So limited disease. What's about a patient still limited disease but having a local fistula or let's say some sort of complication? Is this also a very good patient, or is this a patient where you would like to have pre-treatment and then early surgery?
Great question. So I think if the patient has already established bowel damage, even if it's a localized disease, the indication for surgery for me is very clear. If they have a fibrotic stenosis not amenable to dilatation with an endoscope, or if the patients have internal or external fistulas, this is a surgical patient for me. So in the luminal phenotype, that we can have more discussion. The question is also about residual disease or disease elsewhere in the digestive tract. So we see sometimes patients with localized ileocecal disease, but they have perianal disease. And the data from Lyric and all the Danish data, they do not apply for those cases. This is for isolated ileocecal disease only. So I think, yes, we are seeing a lot of room and a lot of rumor for surgery in an early phase on those patients. And we also have to understand that if you operate a patient in the luminal phase, and we showed that with data from Latin America, when we have earlier surgery, as compared to postponed surgery, the results are much better. So the rates of leaks and other complications is extremely low as compared to operations with established bowel damage. So it's also good for the patients and also for the surgeons.
Yeah, that sounds really interesting and exciting. We as gastroenterologists used to be afraid that after the first surgery, the second surgery would come, or the third, and times have changed. We have a lot of post-operative tools to really manage it. But now with 10 years of Lyric and your own experience, how many of those patients who were initially operated and early operated, how many of those have to undergo a second surgery or third surgery?
Yeah, so these numbers are falling down, I would say. So now when we do an operation like this with this kind of strategy, we also have to stratify the patients in terms of risk factors for recurrence. And those patients with some risk factors for recurrence, we also, of course, we push hard on medical therapy and try to prevent future, active disease and also a recurrence and bowel damage. But some patients do not have risk for recurrence. And those are the patients that we can watch and wait. And our strategy is to monitor those patients regularly in yearly basis with colonoscopy and also with calprotectin and ultrasound. We can manage those patients and monitor them very, very tightly in order to try to detect early recurrence once it happens, and then to push hard on medical therapy again. But definitely we are seeing less cases of, so to say, recurrent need for surgery with optimized medical therapy after surgery.
So you already mentioned, and this was one of my next questions, the post-operative management of these type of patients. Is it different compared to the more complicated cases, the ones we used to have in our clinics before, after more complex surgery? So would you still do the poker-like scheme of doing colonoscopies, or just sticking with calprotectin or intestinal ultrasound? What is your approach here?
Yeah, that's a great question. So let's make two different scenarios. So first scenario would be a Lyric style patient, luminal disease, naive to advanced therapies. For the option of the patient, he decided or she decided to have an ileocecal resection. We perform a minimally invasive ileocecal resection, no problem at all, no risk factors for recurrence. Those are the patients that we monitor regularly. So we do calprotectins 3 or 4 times a year. We do colonoscopy once a year, and the first one after 6 months, and we can also monitor them with imaging tests where whenever available, ultrasound, if not available, sometimes MRE or something like that. However, patients with complicated disease, most of our patients, they already come to see the surgeons with previous therapies, sometimes failed to 2 or 3 mechanisms of action of an advanced therapy. So those are the patients that are at a high risk for recurrence. And again, we have to sit down with a gastroenterologist and we have to make a decision after the resection. Usually what I do, I see the specimen in detail with the pathologist. For example, if there's a lot of fibrosis, probably the last therapy was not very well indicated, so we can keep with the same agent after surgery and monitor. However, if we have a very inflamed specimen, definitely the previous therapy is not working to reduce inflammation, so we can discuss a switch to a different mechanism of action. So those are the patients that need a lot of attention from our part in order to try to prevent recurrence and block the need for further surgery.
Yeah. I like the last point really a lot that you mentioned. You look at the specimen and you also discuss with the pathologist, and like earlier when you said we are our own MDT because you do everything.
But not a pathologist.
You're a part of gastro, you're a big colorectal surgeon, so now you're also getting into pathology, and I think this is probably very helpful because you have the direct look, and this is what we always request from our surgeons. So how did it look? How did the rest of the small bowel or large bowel look? This is very important, or?
Yeah, this is very important. So it's part of our routine to document pictures and also movies of the specimens. And again, it's very important for our pathologists as well to check the margins. So sometimes if you have like microscopic inflammation in the margins of the resection, this is not prevention of recurrence. This is treatment of, residual disease.
Yes.
It's completely different. So it's very important to see the margins in terms of the pathologist MDT role.
Yes. I would now like to switch gears a little bit and go probably to a more controversial topic, and this is the role of appendectomy in patients with ulcerative colitis and perhaps even prevent disease or improve the disease if you already have ulcerative colitis. For me, as a gastroenterologist, doing an appendectomy on a very healthy patient, must be a somehow high-risk patient, seems still a little bit strange, and the background, at least the immunological background, is probably there, but I would like to learn about your opinion on this very exciting area of research.
Yeah, isn't it fascinating? Huh? The appendix playing a role in ulcerative colitis. We know that the immunological, profile of the appendix, there's something there. There's probably microbiome alterations and an immunological role on the large bowel. So yeah, the fact is that data from appendicectomy, and you see we have now data for 3 different scenarios. So the first one was patients with refractory disease, or what means patients almost undergoing a colectomy for refractory disease. And the PASSION study studied not a big number of patients, but 30-something patients. They performed an appendectomy on those patients, and 1/3 of them, they didn't need a colectomy on the long term. So we could prevent colectomy in very difficult to treat patients with a simple appendicectomy, which of course called the attention of the IBD community. And again, if you take into account data from clinical trials from failed patients, it's almost the same. 1/3 of patients with remission, 1/3 of patients with appendicectomy, they could prevent a colectomy. So that's the first scenario. So the second scenario for the ACURE trial was another one. So patients in remission with 5-ASA or other therapies for ulcerative colitis. And then they stratified patients into 2 groups. The first group to keep their therapy going, and the second group to add an appendectomy and keeping the same therapy. So patients with the appendectomy, they had less flares of the disease over the long term. They did better in terms of keeping their disease in remission with an additional appendectomy onto these patients with remission. So again, it can be useful to prolong remission in those patients. But I mean, the third scenario is probably the most interesting one, which is the Costa study. So they got patients in a patient preference randomization, which means that patients could opt for, after failure of anti-TNF, to go for a JAK inhibitor, mostly tofacitinib. This is important. Few patients had upadacitinib, but the majority of them, they had tofacitinib, or they could go for an appendicectomy. And the appendicectomy technically is a little bit different than the ones we do for appendicitis, because we have to take out and excise the bases of the appendix in the cecum, doing a tangential stapling of the appendix. So we take off the appendix and also the base of the appendices in the cecum. And those patients, they were there followed up. And you could see that appendectomy patients, they had higher rates of clinical remission and also higher rates of endoscopic remission as compared to patients with the JAK inhibitor. So one may criticize the study by saying, well, there's only 15% of efficacy in the JAK inhibitor group. I understand it's a low number as compared to what we saw in clinical trials, but the authors did a systematic review of patients in the same situation, failed patients, and it was 15%. So I think the numbers are there to be carried out, and probably appendectomy can be a very useful tool in terms of preventing active disease or treating active disease in ulcerative colitis, which means the new ECHO guidelines are now implementing appendectomy as an option for those patients.
I think this is really fascinating, and for clinical trials with drugs, we would always say, still a limited number of patients, but you mentioned it's long-term data, and for me, it's very impressive. The first scenario you mentioned is still, for me, the most complicated, because patients almost close to colectomy, and then you perform another surgery. We are sometimes even afraid to perform a real colonoscopy because we think we induce toxic megacolon or that do something harmful. But this didn't happen in the trial, or can you just tell us about your feelings in this situation? Yeah. How do you select the patients?
So actually, there were no big complications in the trial, as was observed. And I think it's a very safe procedure to be done with a simple general surgeon can do that. And I think it's a very safe operation as compared to a colectomy or an ileocecal resection for Crohn's, so to say. So I do believe that the key there, Axel, is to have patient selection. And which are the patients that are probably responding better for appendectomy? And we now have some clues. First of all, young patients. Secondly, patients that have periappendiceal red patch, the PARP, the sign that we also always see when there's patients with proctitis. You see those red patches around the appendix base. Those are the patients that respond better. And now we have data showing that if you do an ultrasound and the diameter of the appendix is more than 4 millimeters or 6 millimeters, I'm not sure about the number. If they have a thickened appendix, they can respond better. So patients with a chronic appendicitis that is not detectable clinically, those are patients that respond better. So patient selection is also something.
I think this is extremely helpful and will also help our colleagues. You just mentioned now in a sidestep that this type of appendectomy is very simple, but earlier you explained it's a little bit different. So is this something which a specialized colorectal surgeon is doing, or at least in Germany, the regular appendectomy is, I think, the first operation most of the young surgeons do. So is it complicated, or is something you have to consider?
It's just different. It's just different because you have to take out the base of the appendix. Usually what we do is just we do a ligation of the bases and we invaginate it. But in this specific appendectomy, we have a tangential stapling of the top of the cecum. And I think this is very common and a very easy procedure to be done.
Okay, now we are talking a little bit about techniques, and having you here for a discussion, I would like to discuss a little bit the role of robotic surgery, so technical issues, mostly probably something very important for surgeons among each other. But when I attend meetings with surgeons, I see there's a little bit of a fight. There is the group who is really going for robotic surgery, and the other group saying, this is nonsense and it's just too expensive and we don't need it. I would really like to hear your opinions on this type of battle, and where will we be going in, let's say, 5 to 10 years?
Excellent. So yes, robotic surgery is not something about the future, it's already the present. And I think we see a lot of advantages with robotic surgery, colorectal surgery in general. So there's no discussion that the pelvic dissection is much better with the robot as compared to laparoscopy or conventional open surgery. But the thing about the robot is about training, and it's also about the cost. And we understand that the cost has increased with that. But apart from costs, there are several advantages that can be described here. So the patients, they feel less pain, so the need for opioids is much reduced. So no ileus is observed when you do robotic operations. It's very rare that we see ileus, post-operative ileus. So the patients recover fast and well. And there's also data in IBD, I would say, that we have lower rates of conversion to laparoscopy or to open surgery using robotic techniques. But for example, to do a total proctocolectomy with a pouch with the robot, it's feasible. But again, it's a 6-hour procedure. You have to redock the robot and reposition, so it gives you a lot of work, but the advantages are there and are clear. However, for example, for an ileocecal resection in Crohn's, the anastomosis is much better to be done intracorporeally with the robot. You can suture, you can staple it in a very controlled way. And again, you can have the advantages for the patients. And again, the fight is there. It was the same with laparoscopy. Some old surgeons would say, well, it's never going to be the standard of care, and it became the standard of care. I would say that in the future, in 5 to 10 years from now, we have more platforms available, not only one brand, but several brands of robots, and the cost needs to be reduced in order for us to have a democratic access to the robot in the world.
Yeah, I see in our clinic we use robotic surgery, and the patients really recover early. As you mentioned, we do not see patients having ileus after this type of surgery. So I think this is very good. And my surgical colleague at home always tells me it's so wonderful also for the body fitness. It's much more relaxed and you have the best view whatsoever. And initially when they started like several years ago, they were thinking there would be complications, or when you need to convert, they never convert because they think they can now solve all the problems just with the robotic way. Can see much better. Is this also your experience?
Yes, it is. So the vision is a 3D vision that you go into the console of the robot. It's impressive. So you control bleeding in a more defined way. And I would say that, yes, conversion rates are pretty low, because if you indicate quite well the procedure, you're never going to have a conversion, because the technique is much easier to be done. What you don't have to do is to force the indication for the robot in hard cases. For example, patients with 3 or 4 previous laparotomies, patients with a lot of adhesions. So those are the patients that probably won't have the benefit of the robot. But I would say that in 5 to 10 years from now, we're going to see more and more those cases, because the trauma in the abdominal wall, despite the number of trocars, is reduced. So I think the recovery of the patients is much more, much more adequate for these cases.
It may be also helpful to guide colleagues. I see very impressive pictures of my colleagues when they do liver surgery, for instance. They use artificial intelligence. They inject dyes like indocyanine green, and then they can see where a tumor is and where a tumor is not, and they can see vessels, and even they get warnings. So be careful, there is the bile duct, there may be this. So I don't know if this is also suitable for colorectal surgery.
Yes, there are several ways that this can be improved, and I think the future is going to book for us things like that. So, for example, we can identify the ureter in difficult cases with indocyanine green fluorescence. We also can have, a better detection of the blood flow to detect for ischemia when we do an anastomosis. So I think this is also the future for us. We're going to see more and more technology helping us to do that. And one thing that we can do now is that we can embed the imaging, the cross-sectional imaging of the patient to the case. And if you do a wrong plan, for example, the robot can block and can warn you, this is the wrong plane, and then you have to go for the other way around, and that's the way it's done.
And is it also helpful for educational purposes? I don't know how it's in Brazil or in other areas of the world, but usually in Europe, at least in Germany, you have to be first to be trained in animals, and you have to be certified, and then you have a mentor who is supervising, a proctor, and they do everything. This seems to be much better than common surgery, because you really have a tough problem, and you can be even monitored with your complications and everything.
That's right. So you have to go through all the steps of training. You start with the simulator, and then you do the in-service with the robot in the operating room with some models. And then afterwards, you can train with proctors that they can do, for example, dual consoles. You can have dual consoles, and you can operate like learning how to drive. So you pass the command to the proctor, and then you pass the command to the student again, and you can teach students how to operate much better in this case.
Paulo, this was great. It was a wonderful discussion, and I think we covered a lot of different topics, early Crohn's disease and surgical cure. We were talking about appendectomy in patients with ulcerative colitis, and now what is not even the future, what we have now, robotic surgery in IBD. It was a great pleasure to talk to you. Thank you so much. And to our audience, I hope you liked this podcast. If you like us, you can like us, you can write something below, and we are happy to see you pretty soon again. The next episode of IBD Essentials coming in 2 weeks. Thank you so much.